Hi, my name is Jason Wasfy. I'm a cardiologist here. I'm one of the medical directors of the Mass General Physicians Organization. I'm delighted to be talking today with an old friend of mine, Dr. Nancy Way, medical director for Clinical Informatics at Mass General Hospital. And so, Nancy, I guess what I'd like to talk to you about, because January 1, 2021 is going to be a change in how we do outpatient E&M coding as part of a federal initiative to reduce physician burden. So we'd just love to hear more about what that means.
Oh, great. Thank you so much for having me. Outpatient E&M codes are being redefined as of January 1st of next year as part of this overall federal initiative in partnership with the AMA to decrease physician burden. So this will impact how you choose your level of service in the ambulatory encounters and potentially decrease documentation burden. The big note to this is that it's only in the ambulatory setting and only for level of service E&M codes. The codes themselves are not changing.
And so I guess my sort of limited understanding of this is that one of the changes is you could actually bill for time outside the face-to-face encounter, right? So like if I have to look at an echo from an outside hospital and measure things myself, I could actually bill for that even if I wasn't with the patient at the time. Is that right?
Yeah, so on the day of service, the biggest changes to this or the documentation for outpatient visits will center around how the physicians think and take care of the patients on the day of service. So outpatient physicians will no longer need to document a specific number of review systems, history, clinical exam to meet billing codes based on medical decision making. And what you're touching upon is a big one. They will be able to bill based on time, including any time, non-face-to-face time, on the date of service. So if you spent 30 minutes reviewing the chart on the day of the visit before or coordinating care like an echo after the visit on the day of service, you can include that time-based billing. And there will be a smart phrase to help facilitate this type of documentation. The big thing to note, though, is that the actual time-based billing allotments are going to change to reflect the inclusion of this non-face-to-face billing time. So instead of the standard 15, 30, 15, 25, and I think 40, there are new time intervals.
And those time intervals presumably can be longer, I would imagine, right, to account for this
Yes.
out of face-to-face time. I mean, to me, it sounds good, right? Because to me, actually, the most important thing often especially when I see a new patient, is sort of to digest the information that maybe have been obtained at outside facilities. And often I remeasure things myself or review the primary data myself. Whereas I sometimes feel review of systems is not totally helpful in many cases to medical decision making. So to me, it sounds like it aligns it more with how we practice medicine in the ambulatory setting.
That's right. That's right. It definitely, it's more in meeting, particularly for the medical decision-making type billing, it is definitely in line with how we actually take care of the patients and think about their clinical care.
And presumably, though, this time does not include writing the note, for example, after the visit.
It actually does on the day of the service. So if you spend time after, the time that you spent writing the note during the day of service can be included. That is non-face-to-face time.
Interesting. So even if I'm writing the note after my kids go to bed, as long as it's on the same day, it sounds like that still counts.
Yeah, before midnight.
Before midnight.
But I hope that you don't.
It's not always before midnight that I get the notes done, but I guess when I can. So this sounds like a big change. It sounds like it's in general going to sort of address really encapsulate the full amount of the work that we do to take care of ambulatory patients. What do we need to do to get ready? Because I know this is only coming in a few weeks on January 1.
Yeah, so the administrative directors and executive directors and practice managers have already been made aware of this, and as well as the clinical leadership as well. The policy, and they have been developing plans and setting plans within the divisions and departments for this. The policy site to see what your department training plans are is up and available now and will be linked from this video. The department elected from 3 different training models: a webinar-based one, health stream, or division faculty meetings. And if your department chose to do a departmental training in a meeting, it's okay. You can always use the webinar or health stream to fulfill and to be able to get this type of training. They are already starting to enroll the webinars and have already started scheduling these faculty meetings. So just be aware, and if you are curious as to what your division has chosen, I highly encourage you to go to the Apollo website.
This sounds great. I think it sounds like a change for the better. And I remember even 2 years ago when we were giving guidance during the federal rulemaking period when they were soliciting guidance. So it's nice to see this kind of come to fruition. So thank you so much for talking to me with this, and hope great to see you. Hope you and your family are well, and take care, and hopefully see you soon.
Same to you.